Hello and welcome to DAS Health webinar, NCQA PCMH Certification for Next Gen Enterprise. My name is Bridget Peterson and I am part of the Government Incentives team for DAS Health. Before I get started, I would like to take a moment to explain the process for today's presentation. First, I would like to mention that this webinar will be recorded. We'll send out a copy of the slides and recordings within the next week. Next, for those of you who aren't familiar with DAS Health, I encourage you to visit our website, connect with us on LinkedIn, and subscribe to us on our YouTube channel where you can access all of our historical webinars. I also want to mention upcoming educational webinars we'll be presenting in March and April. The first is Lessons Learned from the Pros, MIPS Submissions Do's and Don'ts on Wednesday, March 15th, and MIPS Math 101, the ultimate guide to MIPS scoring. We will be sending out an invitation to these a week or so before each date, and we always post on our LinkedIn page as a reminder. So keep your eyes peeled for that. Okay, so back to today's webinar on achieving NCQA PCMH recognition utilizing NextGen Enterprise. For audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you are experiencing audio issues, please use the chat box to let us know so we can help resolve them. So without further delay, I would like to introduce our team who will be your presenters today. Myself, Bridget Peterson, a Government Incentives Consultant, Lindsay Lanning, our Government Incentives Manager, and Kimmy Watson, our other Government Incentives Consultant. We have all been working with MIPS, PCMH, and many other quality reporting programs for years, and each of us have our own areas of expertise, and we are excited to help your practice in any way we can. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Great. Well, thank you, Bridget. And hi, everyone, and welcome to today's webinar. We have a lot of great information for you today. So again, I'm just going to go ahead and jump in with NCQA PCMH certification for Next Gen Enterprise. Now, as a disclaimer here, we are strictly focusing on the NCQA PCMH program. No other type of PCMH recognition is going to be covered. Although I will say many of the general concepts we cover in regards to things like practice benefits, ROI on PCMH, and how to elevate the conversation at your practice, we'll go through those right away here at the beginning. Those are going to apply universally. I thought it was important to point this out sooner rather than later, just because if you are pursuing a joint commission or URAC recognition, this might not be exact one-to-one match. I do want to point out too, as an NCQA PCMH CCE, I have access to amazing resources, and I've attended in-person trainings that really largely fed into this webinar. Most of the graphics and a lot of the overall content has actually been taken directly from NCQA in order to provide you with consistent and accurate information. So one of our goals, really our main goal with this webinar, is to make all of this information easier to dissect and digest. So I had 400+ slide presentations over 3 full days of training from NCQA. The goal was to scale it down and pick out what exactly you needed to know and add in what you should know. So this means a lot of the takeaways and tips are coming directly from NCQA evaluators who conduct transformation and annual reporting, reviews, as well as what our team has actually learned from assisting our own clients along the way in those reviews as well and feedback. So up first on our agenda is going to just be reintroducing you to the PCMH Basics. If you're already a PCMH and you've completed transformation, this will likely be a review. However, there's still some great information to reiterate the importance of this program in your practice and maintain practice support. It'll also serve as a great refresher to you on what's required until we get to the annual reporting section, which is towards the end, where I know some of you are currently, gearing up to complete for 2023. So for those of you on the call not yet recognized, you may be wondering, what exactly is this? What's PCMH? I've heard of it. What does it mean? Well, PCMH stands for Patient-Centered Medical Home. It's a care delivery model whereby patient treatment is going to be coordinated through primary care physicians to ensure that your patients are receiving the necessary care when and where they need it, but also in a manner that they can understand it. So in summary here, I'm about to blow your mind. The patient-centered medical home really is a model of care that puts patients in the center of it all. Easy enough, great name choice in my opinion. I also want to note, because I do get this question a lot, PCMH recognition is voluntary for practices. You actually choose to participate. It's not required like some of the other programs out there, cough, cough, MIPS, but it does put your practice at an advantage in so many different ways. So how do you gain buy-in at your practice if you're new to PCMH? Or on the flip side, how do you sustain that support to maintain this recognition if you're already recognized? Well, we would recommend starting with these main points. Again, I'm not going to read through all of them, but some main ones here is that many payers acknowledge PCMH recognition as a hallmark of high quality care. So earning this recognition means you're providing patient-centered care that's going to be associated with higher quality, better patient satisfaction, and typically means a reduction in avoidable costly visits to the ED or the hospital for your patients. So as a result, payers provide incentives to PCMH recognized practices and offer benefits from either enhanced reimbursement, preferred provider status. We've also found that this recognition can help you better negotiate your payer contracts and rates as well. And then I think it goes without saying, this model is associated with better staff satisfaction and patient experience. And as you can see, like I said, there's numerous other benefits we've listed on your screen. You can use these as tools or conversation starters to elevate the conversation and gain buy-in, but we're not going to go through them all today. I suggest picking out, what your organization's goals are and highlighting, the top 3 on this slide to get that conversation started. Now, if your providers are maybe still questioning you, we recommend, focusing on these clinician benefits. So I would start with, first and foremost, earn higher reimbursement. I know I just mentioned this, but it's true. The majority of payers nationwide offer either enhanced reimbursement for recognized clinicians or some sort of support for practices to become recognized. So maybe they'll even foot the bill for you. And again, we're seeing some reimbursement rates cut across the board. So this could be a great way to offset that and make sure your practice stays financially healthy. Succeed under macro QPP, aka MIPS. If my voice sounds familiar, it's typically from our MIPS webinars. We love that program dearly. And we're here to vouch that CMS actually acknowledges NCQAs, specifically PCMH recognition program, as a way to receive MIPS credit. So you would automatically earn full credit in the MIPS improvement activities category. And you're very likely to do well in the other MIPS categories. We can attest, really, our team can, just how many quality measures and various practices or workflows overlap in this area. Like I said, we currently assist MIPS and PCMH clients, and we utilize many of the same reports, workflows, and documentation for both attestation and recognition. Another one that we've seen providers, we get really excited about are these maintenance of certification credits. Think of continuing education credits. Several medical boards are going to award NCQA recognized practices these credits to then reduce the burden on clinicians to take on or complete additional activities to keep their certification in check. I think that pairs nicely with reducing burnout. This is a huge topic right now. This model is going to ensure that your team members are operating at the highest level of their knowledge, skills, abilities, and license within their assigned roles and responsibilities. What does that mean? Well, physicians don't want to do what nurses can do, and nurses don't want to do what front office desk or intake staff can do, et cetera. So there's more time for patient care, and you also have more satisfied care teams. And then, of course, this model is going to help streamline processes. Really, you'll see as we get into it, standardized procedures. So a lot of providers also like to use this recognition time frame to really perform a gap analysis and implement processes and procedures that, yes, are absolutely going to improve care for their patients, but also make your practice more efficient, decrease your utilization, and really streamline the business side of your organization. Another really important factoid to highlight, again, this is all about elevating the conversation and gaining buy-in, right? And we do need to highlight ROI on PCMH. So practices that implement this model are going to have to consider the business impact of investing in this. This isn't something that you can do overnight. It's quite the process. So you have to effectively plan for how implementation of PCMH is going to impact your practice financially. So ask yourself, what are the operational and financial considerations for becoming recognized from this primary care practice, let's say. This could be new systems or structures and processes in place. This could be an additional staff or maybe bringing in external staff like our team to support this transformation, and there's a cost there. So to identify this potential business impact, NCQA actually engaged Milliman, which is the world's largest provider of actuarial services, to answer this question for practices. So they actually modeled the impact that this recognition would have on revenue and costs at this kind of hypothetical 10 PCP practice with 20,000 unique commercial members. And what they found was that the revenue impact on, or of PCMH recognition for that practice was between 2% to 20% increase in revenue. It all really depends on the payment contracts in place. But more importantly, in all models, in all scenarios that were run, revenue increases for a hypothetical practice outpaced any costs, resulting in a positive ROI. Again, NCQA has this information in a business use case. It's downloadable from their website as well if you want to learn more, if you think this would be a really good tool to help elevate that conversation in your practice as well. Now, I think a lot of practices who are considering PCMH aren't sure how to, again, relay that value, or they're often tasked with the burden to prove why this would benefit their practice and your patients. Even practices, out there right now who are already recognized and they're phasing into annual reporting, we're finding have to kind of defend this PCMH status and answer questions like, why are we doing this? Is it even worth it? So that's why we wanted to provide you with those tools to elevate that conversation. Now we're going to move into the recognition structure just as kind of a high-level overview of eligibility and the process. So Kimmy, it is all yours. Take it away.
Thanks, Lindsay. So you already mentioned we would be focusing on NCQA PCMH recognition specifically, and that is because, NCQA offers the most widely used PCMH recognition program for providers, and they're using standards which were redesigned in 2017. And NCQA's Patient-Centered Medical Home Recognition Program is the most widely adopted patient-centered medical home evaluation program in the country. So now I will say, there are other accrediting bodies like Joint Commission or URAC, as well as a number of local, state, and national PCMH recognition and accreditation programs that exist. And there are even some payer-specific PCMH programs I have seen and worked with. However, the NCQA program is the gold standard. It is what almost all EHR vendors recommend and work with, which is why, as Lindsay said in the beginning, if you're participating in one of those local, state, or payer PCMH, this webinar will still be helpful to you because so many of their requirements will probably align with the NCQA. And if you're asking yourself, this all sounds great, but where do I even begin? The first place I would start is with eligibility. Clinicians who are eligible are those that hold a current unrestricted license as a doctor of medicine, so an MD, a doctor of osteopathy, a DO, or advanced practice registered nurse, which is APRN, or a physician assistant, which is the PA. So only clinicians who can be selected by a patient, family as a personal clinician are eligible to be listed. Now, an eligible practice consists of one or more clinicians, including all eligible primary care clinicians who practice together and provide primary patient care at a single geographic location. So practicing together means that all the clinicians in a practice follow the same procedures and protocols and have access to, where appropriate, and share medical records, which are paper or electronic, for all patients that are treated at the specific practice site. So these also need to be outpatient primary care practices. And a practice in NCQA's eyes is a clinician or clinicians practicing together at a single geographic location. So to be specific, that this can include, nurse-led practices in certain states. However, it does not include urgent care clinics or clinics only open on a seasonal basis. It is important to note now, however, that recognition is achieved at the geographic site level. Have we said that enough? The physical site is what's important. This means one recognition per address, and all MDs, DOs, PAs, and APRNs at that address are listed on the application, since all eligible clinicians at a site must apply together. Clinicians should be listed at each site where they routinely see a panel of their patients, and non-primary care clinicians shouldn't be included. This means that, at least 75% of each clinician's patients should come for, first contact for care, continuous care, comprehensive primary care services, or even they should just identify them as their PCP. There is, multi-site eligibility available, but you must answer yes to all three of the following questions. That are, can your organization sign one PCMH program agreement to cover all sites applying for recognition? Do all the practice sites applying for recognition share and use in the same way a practice management system, registry, or EHR to document patient care for administration and billing? Or I should say, and do all practices sites applying for recognition operate under at least some of the same policies and procedures? If you can answer yes to all of these questions, you're eligible for multi-site recognition, which means you can share credit across sites. So you would have one primary practice that submits all the evidence that can be shared by the rest. There are some criteria that are site-specific, but overall, this makes the process much easier for large multi-site practices. All right, well, I'm going to turn it back over to Lindsay, who has taken NextGen clients through both the transformation and annual reporting process to take us through the scoring and standards. Lindsay, it's all yours.
Perfect. Thank you, Kimmy. So again, once you've done that initial step of determining if you're eligible to become a PCMH, the next step is actually understanding how this whole recognition process works, and really knowing and identifying what your practice needs to do to meet the requirements. So let's look at the structure of the program and how it's set up, because it is unique. The program has actually evolved to feature, over the last few years, to feature a set of 6 concepts. And these concepts are really going to be, I think of them as the overarching themes of PCMH. So to earn recognition, your practice must complete criteria in each concept area. Next is competencies. These are just used to categorize the criteria. They don't offer credit. They're more of just a way to think about or group the criteria. Honestly, we don't refer to them too much. We typically focus on the concept and then the criteria and the components. So the criteria basically are the specific activities which your practice must engage or complete to demonstrate that you're meeting the recognition requirements. So these are the actual individual tasks or things you have to do or have in place that make you a PCMH and actually transform your practice. And then lastly, within the criteria are components. These are the individual parts of the criteria that are broken out where evidence would be attached. So credit for something is assigned at the criteria level, and evidence to support that activity is attached to a component. This took me a while, right, to truly conceptualize and understand and really get a grasp on how it works. So it wasn't until I really dove into the standards and guidelines that I understood how this structure actually functions. So if you're confused, don't worry. I'm going to explain it again and again, and you're likely not alone. So the 6 concepts, right, or overarching themes, we'll call them, of PCMH are pretty straightforward. I actually selected this graphic with different shapes and sizes on purpose to show you which ones have the most amount of core criteria found in them. Think of absolutely required activities that you have to do. So you have team-based care and practice organization. This theme or concept focuses on practice leadership, It's going to outline your care team responsibilities and orient your patients and their families to what a PCMH is. This is a smaller square, which means it has a lot less criteria compared to other standards or concepts. So next is knowing and managing your patients. This deals with data collection, think medication reconciliation, clinical decision support, and then also includes connection with community resources, thinking of social determinants of health, things like that. So this is one of the largest standards with some of the most, if not the most, core criteria required by practices. Then to kind of skip out of order here, we've got patient-centered access and continuity. This is going to, focus on access to the practice and clinical advice, care continuity, and really patient empanelment to make sure your patients are seeing, their specific PCP consistently. Care management and support. So this is actually identifying patients for care management and making sure that that care plan is person-centered and developed. Care coordination and care transitions, again, focusing on management of lab and imaging results, also tracking and managing patient referrals and care transitions. And then lastly is going to be the performance measurement and quality improvement. This is another big one. It's going to focus on collecting and analyzing that performance data. We oftentimes do this in the form of clinical quality measures. Those ECQMs you report under MIPS, those play a huge part here. It's all about setting goals, showing, improving or performance improvement in your practice, and then also sharing your performance data with all the stakeholders, patients included in your practice. So you're going to see, for every criteria, basically a breakdown like the one on your screen right now. You have your concept, which uses a 2-letter abbreviation when identifying it. I'll be honest, I didn't even know the whole name for this concept was Team-Based Care and Practice Organization. I knew it was Team-Based Care, but we always refer to it as TC. Then you have the competency, which is, again, just that criteria subgroup, just to kind of give you an idea of what you're getting into, we'll say. And then you have the actual criteria, which states, the PCMH requirements, which is always shown as the 2-letter abbreviation, then a number. So this is key. This is typically how we, break out our project plan, et cetera. So this one is going to be TC01. And then you see you have evidence. And under the evidence, there are 2 components listed that you will have to attach evidence to get credit for that criteria. So again, to meet TC01, we've got to upload two things of evidence or 2 forms of evidence here to actually meet that. So it can sound confusing when you're trying to talk it out. I understand that. I think this visual does help break it down a little bit and make it more meaningful to see how this structure actually works. But we'll, continuously visit this throughout the rest of the presentation. So to receive recognition, practices have to complete 40 core criteria, all 40 of them. I think you heard me allude to this in my descriptions before. And then you have to earn 25 elective credits. So elective criteria are a mix of 1 to 2 credits, and you have to cover 5 out of the 6 concepts. Kind of reminds me of the old PQRS days. You had to have 9 measures over however many domains, et cetera. But the main thing is you need 25 credits here. So again, if you find a criteria that counts for 2 credits, that's going to limit the actual number of elective activities you have to do, which is great. And it has to be, again, out of 5 of the 6 concepts have to be covered. And then, specifically, each criteria in the standards is noted with its assigned value, right? So you can see on the image on the right, it's showing how many credits are available under each concept and competency. So that's that breakdown that we're seeing here. So if we think about this, we have 40 core criteria and then 60 elective available. You need to get 25 credits for the 60 elective. Here's another graphic. I'm hoping this will help you better understand how the elective scoring works, and also one that shows you, same thing, the breakdown of the core criteria within each standard. So this is going to show you exactly why I made the blocks over on the previous slide, different sizes. You can see KM and QI clearly have the most required core criteria if you're going to compare it to TC or CM. Now, I'm assuming most of you are wondering, okay, got it. How do we actually meet this criteria? Or how does NCQA know we met this criteria? What do we need to do? And that's where evidence comes into play. So you're going to have to submit evidence demonstrating performance against, each component of a criteria. Some encouragement that NCQA has offered is that you need to implement and document any process-based evidence early. So it needs to be at least 3 months prior to when you're saying, you're attesting to this. So if you roll out a new process and then you upload it and it's only been in effect for a week, NCQA is going to say, no way. They need to be in effect for at least 3 months. And then any data you report, so think QI, think those ECQMs, et cetera, they can't be any older than 12 months, right? If we're testing in 2023, we're going through the recognition process and we're going to upload data from 2020, that's not going to fly. So I think these are pretty straightforward, but just as reminders. So again, think if you were ever audited, you have to back up and prove you were actually doing the things you attested you or said you were doing. So this is the same idea. You have to prove you're actually meeting the criteria you selected by submitting evidence. Again, this initial transformation process, we're going to submit evidence for everything selected to get credit, but then we move to an annual reporting phase where there's only a few you have to do each year to keep that up. This new kind of, I wouldn't say it's new at this point since 2017, but it used to be that every 3 years you had to go through this full transformation process and attach all this evidence again. So I definitely think, putting everything we have into the evidence that's needed for the first time around is the way to do it. And then we can just maintenance, keep it up in annual reporting. So I digress. There are 2 types of evidence here, a documented process and evidence of implementation. So documented processes are going to be straightforward, right? Written statements describing, your specific policies or procedures. So if there's any sort of protocols in place, any practice guidelines you have, if this happens, we do this, or any sort of process outlined. You can think of even checklists or flow sheets. That's going to be documented process. Evidence of implementation means really demonstrating any sort of systematic uptake and effective demonstration of required practices. What that means: reports, screenshots, attestations, patient records and examples, ECQMs, survey, any sort of data you enter in QPAS, any sort of transfer credit you get from your EHR, in this case, obviously NextGen. There's no really description for this besides evidence of implementation is really the catch-all for anything that's not a documented process. They don't have any strict guidelines on what that includes because NCQA wants and encourages you to be, flexible with this and think outside the box. But anything that's not a specific process or outlined on a piece of paper, it's going to fall under that evidence of implementation bucket. Now you submit this evidence either, online through your NCQA PCMH portal, that's called QPAS, or through what's called a virtual review, which is basically like a Zoom call with an NCQA evaluator. So now again, with QPAS, you're uploading things like policies and procedures, practice pamphlets, links to your website, things like that. Anything you can think that you would save on your desktop and upload. These are things that your actual evaluator can review on their own time. Maybe they don't need an explanation with it. It's pretty black and white. This is what you want to upload and link to your criteria in your QPAS account. So for example, if you have something on your website that actually meets 2 criteria, you would upload the link to the website once and then link those criteria to it. So it's extremely important to note that you should never upload anything with PHI on it to QPAS. If you decide you want to upload screenshots for any reason from your EHR, you would actually need to insert kind of a box or delete or mask the PHI over it in some way, shape, or form to upload that. So this kind of brings us to our second type of evidence, which is the virtual review. So you as a practice will have 3 virtual reviews during this call or during your transformation process. During this call, you're basically screen sharing with your evaluator. Here, you don't have to hide any PHI. This is why EHR demos to meet certain criteria are encouraged versus a screenshot and removing the PHI. You can also show reports, that has patient information or patient examples during this time. This second form of evidence submission is really helpful. We are going to cover virtual reviews in detail coming up shortly, just with best practices and kind of tips and tricks and things we've learned from NCQ evaluators as well. So if we take a step back, we really look at, a standard altogether. We have the concept, we have the competency, the criteria, and then the evidence required to support that criteria assigned to a component being met. You also have guidance from NCQA, and guidance includes things like expectation, aspects of the evaluation process, terminology used, how this specific component maybe relates to another criteria, and then information on the intent of it as well. And our recommendation, it's extremely helpful. Never overlook the guidance. It's going to be, the best kept secrets of NCQA and direction on how to meet something. But really, that is it. That's how you determine what's required for your practice to become a PCMH. That is the transformation of your practice to meet those requirements and provide evidence to support those activities that will earn you the recognition. So again, that's the actual process of how to gain recognition, where to go, what to submit. Once you've met the core and elective criteria that's left for us to look at, I'm going to turn it back over to Bridget just briefly, and then we can get into how you would actually get credit for criteria actually using the NextGen EHR system. So again, this is more or less the admin side after you've actually done all those activities and submitted the criteria.
Great, thank you, Lindsay. Okay, so first off, you need to determine if you are eligible, and then it's recommended you perform a gap analysis of your practice and identify where you might need to transform. You're going to be looking for things like, does your practice have leadership in place, a certified EHR with pre-validated transfer credits, or a communications plan to engage patients, including a portal? Do you participate in a value-based agreement supported by Health Information Exchange, and do you report electronic quality measures to CMS? Is your practice knowledgeable of the concepts and already begun transforming into a PCMH? You would then enroll through the NCQA QPass system. You would set this up by choosing sites, adding clinicians, and once you sign the agreement and pay the fee, the 12-month transformation period will officially begin. This is why we say you should really have reviewed the requirements and started making changes in getting things into place for at least the core criteria before officially starting, which in NCQA's eyes happens the moment you sign and pay. You will use QPass to gather evidence, prepare documentation, and track your practice's progress towards recognition. Once enrolled, NCQA assigns a representative as your single point of contact to guide you through the whole process. Your representative will schedule an initial call to introduce themselves, discuss the process, and develop a review schedule of up to 3 check-ins over the course of your transformation. Your NCQA rep is your best friend. They are your lifeline and best resource. They are not the ones conducting your virtual review. An NCQA evaluator will actually conduct your virtual review, and they'll determine if you meet criteria or not. Now, once you have completed your check-ins and earned your recognition, each year after, the practice checks in with NCQA to show its ongoing activities are consistent with the PCMH model of care. This is part of the annual reporting process and includes attesting to certain policies and procedures and some submission of data. The process sustains the practice's recognition and fosters continuous improvement. Now, the review process is the last and most critical step. I mentioned there would be up to 3 check-ins. During these, you want to predetermine criteria to address, focusing on core and documented processes first. Then identify criteria for 25 elective credits. You will provide documents for the off-site review, which includes policies, procedures, and protocols, website links, and even attestations. And then you'll also provide evidence during virtual review. Make sure you communicate with the evaluator, substitute evidence if something is not sufficient, demo your systems, and provide reports. Virtual reviews give practices immediate and personalized feedback on what is going well and what needs to improve. While they may seem intimidating, it is actually so much easier and better for you to develop a relationship and get immediate feedback and get a better idea of what the evaluator is looking for or needs to see. We have had great experience with our last client in these reviews. We will get into tips and tricks on the next slide, but we all had resources on the call that we may need. We had billing, IT, clinical project leads, our CCE, etc. And we also conducted an internal mock virtual review before each one. So it went extremely smooth and with the plan in place to know who would show or present what. Also, we were able to complete it in only 2 virtual reviews instead of 3, which took the pressure off. Okay, so I got a little ahead of myself there, but here are some more tips and tricks. First, you need to know these check-ins are limited to 2 hours. That's it. Second, you need to know you have to have a max and minimum number of components you can have at each check-ins. You will mark items in QPass to go over in the virtual review prior to the meeting so that you will know exactly what you will be presenting to the evaluator. Again, my advice is to try and complete everything in 2 reviews so you have an extra just in case for any straggler criteria. Otherwise, you have to purchase a 4th. Due to the time and component restrictions, this is why we say upload all documented processes beforehand. Also, transfer credit achieved by your EHR vendor, in this case NextGen, which we will look at, does not count towards your total components. This means you can mark those done and not include them in your total. Also, any shared credit, if you are multi-site eligible, will be reviewed at one practice and then marked as met for the rest. But with this first check-in, focus only on core criteria because you know you have to get these done. Make sure to run any reports you plan on showing before the call. You do not want to waste precious minutes watching your EHR load a long report. Make sure if you are doing a demo to have an actual patient example already pulled up, or if a screening tool is being used to meet criteria, it needs to be filled out. And other general tips and tricks is have the right staff available, have all necessary people you need in the room, whether it's your nurse, front office, billing, IT, clinician, CCE. Also make sure that you have checked Skype and Zoom, the setup and mic connection before the call. Have systems and reports ready up to 15 minutes prior to the check-in, and keep descriptions concise and to the point. You only have 2 hours. You can revisit a criteria during the session if you have time. Again, these are all about preparation and organization to use your time wisely. You can get a lot done in 2 hours if you are prepared. So after check-ins, the evaluator marks criteria is either met or not met. The practice can then work on not met criteria prior to the next check-in. After all 3 check-ins, if the practice meets all core criteria and 25 elective credits, results are forwarded to the Review Oversight Committee, the ROC. If required criteria is not met within 3 virtual check-ins, an additional is available for purchase. If the survey process is not completed within 12 months, additional time can be purchased. So we've taken you through a lot of the actual process of gaining recognition as far as uploading evidence to QPass or showing it in a virtual review. But we wanted to make this presentation to be meaningful to help you understand what NCQA is really looking for to actually meet that criteria. So we pulled 1 to 2 core criteria from each standard to briefly show you some examples of evidence. I'm going to turn this over to Lindsay since she played a large role in gathering evidence for our last client to take us through these examples.
Awesome. Well, thank you, Bridget. So let's jump right in, right? First is going to be TeamBased Care, so TC. So the first criteria we're going to look at is TCO2. This wants you to define practice, organizational structure, and staff responsibilities to support key PCMH functions. So you can provide an org chart to meet this criteria. Just upload it to QPass. However, we've done this. Lesson number 1. You really need to read and reread the description and take it literally. It says structure and role/responsibility. That means if you uploaded an org chart that didn't list staff responsibilities under it, it's not going to fully meet the criteria. They're going to ask you for more. You need both parts. So look at the example image on the top. This has both. You could submit an org chart that, if it's not this, you could submit just a regular org chart that has the role and the name and shows the structure. And then you could just submit a job description for each role on the org chart if you already have those created. And that's kind of lesson number 2 here. Evidence is flexible. NCQA encourages practices to do whatever works best for them and to think outside of the box to meet criteria. There really is no one size fits all when it comes to evidence here. And that's the point. This should be unique to what actually fits your practice and what you're already doing or already have. Another standard under team-based care is TC09. This states that you need to have a process for informing patients and their families or caregivers about the role of a medical home and provide materials that contain this information. So this screenshot below is from a pamphlet given to all patients in the practice that explains what a medical home is and what it provides. You may also add a similar section to your website and then use your website link as evidence. Just be prepared to also prove all patients can access this, meaning they have internet access. Again, we've gone through this before. We've seen our clients actually have to show a list of patients who are enrolled in the patient portal to then prove that they have access to the internet. So again, flexibility here, and really reading between the lines on what they mean for each one of these criteria. So moving on to knowing and managing your patients. Again, this section is really going to heavily rely on your EHR, in this case, specifically NextGen. So KM03 is going to ask you to conduct depression screenings using a standardized tool. So again, our recommendations here, definitely the PHQ2 and PHQ9. Also note, you should be seeing on your screen now, I know we're having a little bit of a delay here, but note that this example on your screen is filled out. The key for any screening tool you show NCQA is that it needs to be filled out. You could not submit a blank template for a screening or a survey. Also, this may be a good one to show during a virtual review as a demo. Another good lesson, always pay attention to the components needed for each criteria. You may need a report and evidence of implementation or a documented process. So again, that means you need both. So you need to submit 2 things before this criteria can be marked as met. Again, this could be a report, and then we could show them this on our actual virtual review. So you always need to, think about that. If it's a documented process, feel free to upload that before, and then show the report or that screening tool, like I said on the demo. Now for KM09, this is going to ask you to assess the diversity of your population. This is also included in annual reporting this year. Again, this is a simple report. You could technically do a physical audit and make it in Excel, again, using your demographic data to show race, ethnicity, and vulnerable population. All of the required parts are going to be explained in the guidance of what exactly NCQA is looking for. That's why I said don't skip it over, or you're likely going to leave out a key piece of information that they want. Great news, NextGen already has a reporting function to pull this information from the patient's demographics. But here's the key, your practice needs to make sure you're actually collecting that data so there's data to pull. So we've seen a lot of clients recently make these fields required in practice preferences, for that demographic pop-up. So, front office staff, intake staff, et cetera, can't go past it, they have to collect it. We're gonna switch gears to patient-centered access and continuity. So this specific abbreviation is gonna be AC. So talking about AC01, this is a core criteria. It's looking at ensuring your practice assesses and reviews the access needs and preferences of your patient population from collected data to determine if your existing methods are sufficient. So if we look at, you should be seeing it now, the top screenshot, you can see survey results, their answers specifically, and then pie charts that analyze the data. Now, what I want to point out here is a big lesson learned, especially in this standard, is that survey questions need to be actionable. They cannot be yes or no. They need to allow the practice to take action and make a change based on the data. So it's not, would it be beneficial to open another practice location to better serve you? It's, would it be beneficial to open another practice location to better serve you? If so, please list your zip code. So you need to make sure you're collecting actionable data. Now, AC05 asks you to document clinical advice and then reconcile this after hours advice in the patient's chart or record. This is a great example of having to show 2 components. It wants a documented process. So we're going to have a process in place that states what your practice should be doing. What's the policy in place for this after-hours clinical advice? Do you have an after-hours call center? Do you have someone on call each night? What's the process? And then the actual documentation in the medical record. So, showing an actual after-hours, which we have here in the screenshot of, someone putting in the chart, maybe it's a telephone call note that was done after hours, and that's your basically proving your evidence of implementation. So you can kind of see in that example how those two play off each other and why both are needed, really. We're going to look at care management and support next. So this is the CM. So two core criteria we're going to look at. First is going to be CM05. This one is really focusing on if your practice provides a written care plan to your patients under care management. Again, don't overthink it. This is a good one to provide a patient example during a review for to show a care plan was reviewed and provided, especially in NextGen. It's right there. Obviously, you can open up the encounter, but it's going to be right there front and center. And then we have CM03. So are you identifying patients at high risk using a comprehensive risk stratification process? So this is a good example of something else you may come across. You may have some criteria that will actually automatically allow you to meet other criteria. So if you meet CM03, you get auto credit for CM01. That's because basically CM03 is more sophisticated. It takes CM01 to a whole new level by actually having a risk stratification process, such as, if you had NextGen analytics in place. That's much more comprehensive than if you met CM01 through, a physical patient audit. So that's another theme you might see is different criteria, kind of two birds, one stone, knocking two out. And we love that efficiency. Next is going to be care coordination and care transition. So this is going to be documented with CC. So CC07 is going to consider, available performance information on any sort of consultants or specialists that you refer your patients out to. Again, two great examples here. One being an Excel spreadsheet that tracks a bunch of different things, right? Two birds, one stone. We love that. You could also go into, if you didn't want to do the Excel spreadsheet, you could also look at, let's say, physician compare, right? We all know everyone's MIPS data and performance data are being uploaded to the physician compare website. So you could look up your specialist, your practice uses most, and document, what feedback's on there. So there's so many different ways to meet criteria. CC01, it's all about tracking, flagging, notifying patients of lab and imaging test results. Again, very dependent on NextGen. There's transfer credit, which is good. But you still need to upload a documented process to QPass. And then, again, show your EHR example. Again, in NextGen, it's going to show the result in red. We've got it easy. But again, a lot of times we have that documented process. So you can see the level of detail that's on this documented process you're seeing on your screen. Notice it has an effective date and an issue date. Remember, these processes need to be in place for at least 3 months to count. So again, if you're having any sort of trouble with your documented processes, you don't have them, but you need to create them. Again, it doesn't necessarily need to be to that level of detail, but these are overall great examples, and that's something you want to address immediately because of that 3-month timeline. Now, our last category is performance management and quality improvement. This is our QI category. So looking at QI01, if I had to pick a favorite criteria, I think it would be this one, just because it's overlap with MIPS. But you must monitor at least 5 clinical quality measures across 4 categories. The categories I mentioned, will most likely be explained in the guidance. We're actually going to mention them in our annual reporting section here as we finish up. But again, for this specific measure, you want to pay attention to the guidance, and you also have an easy kind of low-hanging fruit here, because if you're using NextGen HQM, you've got this met and then far above it. You've got your ECQM and your MIPS-CQM report ready to go to support this QI01. We do have things like QI15 and QI18. These are to report practice level or individual clinician performance results within the practice. So again, also sending them to CMS or Centers of Medicare and Medicaid. So again, using those HQM reports, showing that it was sent to CMS by showing the submission batch ID from your HQM if that's how you submitted it. But then internally, maybe you have a monthly clinician meeting where as the first 10 minutes you distribute the HQM reports and you go over them. Those meeting minutes and these reports would be great evidence to meet both of these. So again, meeting these criteria is not about reinventing the wheel. It's about making your practice patient-centered. So if you're already doing these things, that's great. Let's get credit for it. Okay. Well, we're going to jump into annual reporting, for our final few minutes here after this, but I want to take a second to put everything together. If there's one slide to take away from this, even though we are sending them all out to you, here are key takeaways and themes for meeting these criteria and for gathering evidence that we wanted to share with you. So we've gathered these, again, from working with clients on transformation and annual reporting over the past 3 to 4 years, but also tips we've picked up on from NCQA trainings that I've had as a CCE. So first, evidence can be flexible. We saw this with the different things you could submit for measures like information on specialists. Many criteria require multiple types of evidence. Again, that documented process plus evidence of implementation is very common. It's really the norm. Screening tools and templates must be completed if you're using them as evidence or in a demo. Criteria focuses on the entire patient population. So this is a newer one, but a lot of times we tend to collect data or focus on a subset of patients unintentionally. I kind of touched on this with adding a link to a website. So with TeamBased Care, where, like I said, we put that information about the medical home in a pamphlet. Let's say you're not doing the website. Let's say you're only doing the pamphlet, but you're only giving that pamphlet to new patients. You aren't focusing on the entire patient population because, again, you have established patients that are not getting that information. Now, on the flip side, if criteria includes the verbiage vulnerable population, that should be focused on. It should be a subset of your patient population. So breaking this down and giving some examples. Hispanic versus single mom versus homelessness versus veteran status could all be examples of a vulnerable population. But the key is that, again, it needs to be vulnerable. Comparing things like literacy rates and girls versus boys won't work. Again, it needs to be a vulnerable population. So this sounds easy, but it is probably the most common thing to trip up practices right now. Then we have the documented processes. Again, we need the date of implementation, and it has to be, in use for at least 3 months. Data used in reports can be no older than 12 months. We know that. And then lastly, have patient examples ready and know what patients were used in care management. Don't be surprised if your evaluator asks to see multiple patients for a measure. You've got 3 examples pulled, but they want to see 6 while you're scrambling. They just want to make sure that you didn't make 1 to 2 to 3 patient charts perfect and immaculate, and the rest don't actually look the same. So just come prepared. And okay, as promised, if you're already recognized it as a PCMH, 1, congrats to you, because that's a lot. You made it this far in the process, but also made it this far in our webinar today. So let's jump into annual reporting for our last few minutes. So after you're recognized, you have to complete the annual reporting process to maintain this recognition. So this is actually completed 30 days before your anniversary date. And that anniversary date is 1 year from your recognition date, right? So just think of it a month before you hit that anniversary date. During annual reporting, you're going to be asked to attest that you're performing the activities that you had originally done during transformation each year. And then, specifically, we're going to look at, are you still doing these activities, and then prove a certain subset. Now, these requirements for annual reporting change each year. So if your anniversary date is in January, your annual reporting date will be in December. So this gets tricky because you have to follow the annual reporting requirements for the year your annual reporting date falls in. So right now we're helping clients with annual reporting according to the 2023 requirements. The requirements for each year are actually going to be announced every July. So in July of 2022, we found out what needed to be reported in, starting January 1st, 2023. We have helped clients whose, annual reporting date is January 3rd each year. And it's always the new requirements that we have to follow each year. Also, again, for multi-site annual reporting, all the practices in a multi-site group will actually have the same annual reporting date unless you request otherwise. And that date is going to be based on the date of the first recognized practice. So it's going to follow suit based off that primary practice's anniversary date. So what does the actual annual reporting process entail? You're going to submit an annual questionnaire. Again, that attestation saying you've kept all your activities going. Then you're going to have an evaluation. This is where you're going to answer questions. You are going to submit or upload evidence into QPass and provide some explanations just for a certain minimum number of requirements under each concept. NCQA will review your submission and then let you know of your sustained recognition status. So again, you're going to have an evaluator who will review your submission and provide that feedback. Typically, a virtual review is not required for this. And then your results will be sent off to the same ROC committee for that final decision. So looking at the 2023 annual reporting requirements, it is interesting, you know, this should load here in a second for you to see the table on your screen, listing them all out. They are aligned. They're basically core criteria, some elective, but mostly core criteria from each concept, but they change the naming scheme. So they basically rename them. You can see AR TCO1 is actually TCO7 in the normal standards. So just to confuse you a little bit more. These have changed since 2022, right? They don't keep the same ones. You'll notice KM09, AC03, and CM14 and 16. Those are all new. They were not included in 2022 annual reporting, so they are going to mix it up. So again, if you've maintained your activities, this is typically going to take no more than 15 to 40 hours of work each year. You can do this over several weeks or months to prepare. Again, these are going to focus on specific key criteria through either evidence submission or attestation. It's less about uploading documents. It's really more of data keeping and pushing certain initiatives forward. So be prepared to spend significantly less time preparing for annual reporting versus transformation. So that's the good news. I do want to call out there is another change for 2023. One, noting that the use of a certified EHR technology will soon be required for PCMH reporting. That has not been the case in the past. But two, also, and I think this plays into it, is that they did update the process to require the use of measures reporting. There's a measures reporting tile in QPass for the QI criteria. So this tile that you'll select, it actually allows you to either use a standardized measure to select basically an ECQM from a dropdown, and it'll auto-populate the measure parameters. Or if you're using a measure not listed, you can enter the information manually, but this will be going away. So for any of you on the call who report under MIPS, this is actually great news. They are the exact same as the ECQM measures used to attest under that quality category under MIPS, and you can get these for dual credit and for clinical alignment. So again, we just wrapped up annual reporting for a client. We preferred utilizing this page. It was a much quicker process for us, but we do encourage you to take note and identify these measures early on. Again, think of a full year's worth of data previous, so you can work on improving performance, because NCQA did say if you have a lower than normal denominator or a lower performance rate, they want an explanation why. So again, we are going to send out a copy of these slides. I know we're short on time here, but I did list out each measures, their category, and then each ECQM identifier so you knew which ones to address, both for behavioral health, immunization, preventative care. We also have some under chronic or acute care, the healthcare cost, and care coordination categories as well. And then last but not least with annual reporting is a word that makes us all cringe, right? It's audit. So please note that a random sample of practices submitting annual review each year are going to be selected for an audit. You're going to be notified via email, and then you basically have to go through. It's not the full transformation. You only have to demonstrate the core PCMH criteria. Again, selection is going to occur after you submit your annual reporting, so just keep an eye out on that. Now, how can we help you? How can we make this transformation or annual reporting process easier? The good thing is NCQA offers a pre-validation program. This is for health IT solutions, specifically electronic health records like NextGen, to get what are called transfer credits or practice support. So the good news is NextGen has transfer credit. NextGen Enterprise EHR has 31 NCQA PCMH criteria for transfer credit. That means 31 of those criteria are automatically met. That includes 15 out of the 40 core criteria, and 16 out of 25 elective credits are just done for you just by having NextGen, and of course utilizing the functions that they're talking about for transfer credit. And then NextGen Office EHR also has some, but looking through our names on here, I don't think anyone's on NextGen Office. Now, in order to claim the transfer credits, you'll have to request a pre-validation letter. That's through the Success Community. You can open up a case for that and they'll send it to you, and then it's uploading it to your QPAS evidence library and linking that to any criteria identified for transfer credit. That pre-validation letter, you can see the updated one from 2020, and you can see it lists out basically what version you're on and everything that would apply, either practice support or transfer credit. Practice support is basically saying that the functionality exists within the EHR, but you still need to prove likely the documented process or the actual functionality, either or one of those, that you're using it. You also have the capabilities matrix, they call it, on the Success Community. Again, this is just going to break down what's available, what reports are available, transfer credit and practice support in a more concise way. It's a great resource to have on hand when you're going through and trying to plan out your transformation. And then lastly, again, from NextGen, they do have PCMH 2017 report solution. It's basically a reports bundle you can purchase. We always recommend it. The reporting capabilities that this thing comes with to just make your life so much easier. Basically, it's required to earn some of the transfer credit, but I mean, the knowing and managing your patient section, the KM section, it absolutely, blows it out of the water, makes it so much easier. So again, if you're a NextGen direct client, reach out to your NextGen account manager if you're interested in that. If we're your reseller, you can reach out to your DAS account manager to look into that and get pricing, et cetera. And then last but not least, I know I'm over on time, but I am a PCMH certified content expert. So I have been certified by NCQA through on-site training, through an exam, et cetera, to help you through that transformation and annual reporting process, which is it's a big help, mostly just because of the resources they provide me that they don't make available to the public. So again, next steps, we definitely recommend you continue to visit our website and sign up for these webinars. I swear they're not always so information packed and go long. And then of course, consider working with our government incentives team. We can offer you guidance and assistance in any form you need it. You'd be working directly with me, Kimmy, and Bridget. Just reach out to your DAS account manager, or if you don't have a DAS account manager yet, feel free to email us directly. We have that governmentincentives@dashealth.com email address. Again, we knew this presentation would leave us extremely short on time, or really on borrowed time here. So I am seeing some questions in the chat. We usually do a live Q&A at the end. Please feel free to email any PCMH questions you may have to us directly. We would like to take the time and make sure we have those answered. We're going to export, Bridget and Kimmy, I think you guys have a handle on that, exporting those questions that are coming in now for us to answer. Perfect. So I know most questions anyway are pretty practice specific, but again, don't hesitate. We're going to answer these questions here within the next few days to get you the answers you need. And if I need to open up an NCQA case, I will for you. So don't hesitate to reach out to learn more information or get your questions answered here from this webinar. Kimmy, Bridget, can you think of anything else I forgot besides going 3 minutes over?
No, but that was amazing. And yes, a lot of information, really valuable information.
Awesome. Okay, guys. Well, I think all that's left is just saying thank you so much for joining today. Feel free to email us, like I said, and continue to sign up for our webinars. And hopefully we see your name or face soon. But thank you.